This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm Justine Feidelson, here with Dr. Dan Bates. Hey, Dan.
Hey, Joss. How are you?
I'm good. Today, we're looking forward to getting into actually an interesting concept that whether you're a patient or a practitioner, I think is really important to recognize yourself and in many cases, possibly better communicate to patients. Because from a patient perspective, we often don't realize that when we're going through the frustrating process of trying medication after medication, it's actually normal to not respond to the first thing you try, or actually many things you try, and oftentimes probably not improve to the degree that you would expect that you would. And the challenging part about this is that with many things, it's like expectations breed resentments. And I have also gone through the process of trying thing after thing, and even that in and of itself escalates the level of frustration and sort of sympathetic drive that you have going through this healing process. And in reality, there's quite a misunderstanding between how effective a treatment is actually likely to be for a patient. And I think there's a bit of a misunderstanding on both sides in a way, from the perspective of doctors expecting things to get better when they prescribe something, and patients, like I said, expecting to get better when they're prescribed something. So Dan's going to kind of talk us through the number needed to treat concept and why it's actually quite different than a lot of people realize when they're going through this painstaking process.
So number needed to treat is the number of people that you need to treat to be able to get one person better than whatever you're comparing it to. So let's say that you're running a drug study and you're testing one drug against the placebo. What you then need to do is you need to treat, say, 7 people or 10 people or 20 people to get one person better than just the placebo effect alone. And so that's the concept of number needed to treat. Number needed to treat can be quite difficult for a number of different reasons, but what it does is it starts to give you a bit of an idea of setting some realistic expectations and coming to understand there's actually no magic bullet. So we do not have a magic bullet to be able to treat people's pain. If we did, I'm telling you now, we would use it all the time. Like if I had a magic bullet, I would say, hi, here's my magic bullet, and everything.
Bye. Yeah.
Bye. But no,
there'd be no central sensitization discussion.
There would be no central sensitization.
There'd be no podcast.
No, there would be no podcast because I would be doing something else. So number need to treat is important. There's a couple of different things. So if you look at number need to treat within the concept of neuropathic pain, okay? So within neuropathic pain, we have 4 main drugs that we use to treat neuropathic pain. And so the number needed to treat to get one person better than the placebo. Now, what does better mean? Oh, that's a really interesting question.
Yeah.
So within the drug environment world, that is a 30 to 50% decrease in pain. Now, and let's be honest, it's not 50, it's 30 because, that's the way it will all work out. And so to get one person better than using a placebo using amitriptyline, I need to treat 4 people. It's 3.4 or something, but you can't have 0.4 per person. So you got to treat 4. When you're using duloxetine, there's a number of different names for duloxetine. It's also known as Andipra or Cymbalta. You've got to treat 6. When you're using gabapentin or pregabalin, gabapentin is Neurontin, pregabalin is Lyrica, you need to treat 8 people. So I've got to treat 8 people with pregabalin to get one person 30% pain relief above the number of people that are just going to get it out of placebo. So that puts it into a real context of what you want.
Yeah, like let that sink in. It's unlikely it's going to work for you. It's unlikely it's going to work well.
Yeah. And there's a good chance that what you're getting is a placebo effect. And in that setting, if you're getting some pain relief, but you're getting a bunch of side effects,
right?
You got to weigh that up. Are the side effects worth the degree of pain relief. And if they're not worth the degree of pain relief, well, you got to chuck them out. And so,
Right.
we wrote a paper 5 years ago now that brought together all the international guidelines on management of neuropathic pain and developed an algorithm out of it. And one of the important parts of that algorithm is that it should be a 4 to 6 week trial of a medication. Like, try it, gradually build up the dose. If you tolerate it, great. If you don't tolerate it, that's okay. That just makes
You're
you normal.
Right.
Yeah.
Yeah.
And if it doesn't get you the pain relief, it makes you normal. So that's okay.
Right.
Now, if you take that into a different context and you look at back pain. So back pain, we're moving it out of a neuropathic pain environment and we're looking at different medications. And so in that setting, you can look at things like you look at exercise, you can look at oral anti-inflammatories, acupuncture, capsaicin, duloxetine once again, and then opioids. And so there was a great systematic review that was done by Kolber and a group of colleagues that looked at what was the number needed to treat for all of the things that we just talked through. And so let's, if we just go through that. So if you look at what do you need, how many people do I need to treat with an exercise program to achieve 30% decrease in pain over and above a placebo effect? And the answer is 7. So I've got to treat 7 people with an exercise program. Now, the duration of that exercise program is a little bit uncertain. So within these studies, they followed people up from 6 to 52 weeks. I haven't, completely dived into how long did those exercise programs go for. You can assume they're going to be somewhere between 4 and 52 weeks. But what you get out of that is that, with an exercise program, 50% of people got a 30% decrease in pain. And then with those people who were treated with placebo, 35% of those patients got a 30% decrease in pain. So 15% of the patients actually had a positive effect from
the exercise.
Because of the exercise.
Right.
So what's important with that? What's important with that is that if you're doing the exercise, there's a 50% chance you're going to get a 30% decrease in pain. That's not terrible.
Yeah.
Because at the end of the day, no matter what you do, there's going to be a placebo effect for whatever we do. If we do something, your body is going to respond and provide its own physiological mechanisms that trigger off a placebo effect. If you then look at oral anti-inflammatories, the number needed to treat is 6. So interestingly, 55% of patients that take an oral anti-inflammatory will get a 30% decrease in pain. 37% of those patients was due to placebo. So, the remaining, whatever that is, 18% is because of the anti-inflammatory itself. And so the number needed to treat there comes down to 6. Acupuncture, the number's essentially quite similar. Interestingly, capsaicin. So capsaicin is chili powder in a cream. What it does is it burns and desensitizes areas. It also acts as a distracting type mechanism. 64% of patients got a 30% decrease in their pain. 46% of that was due to placebo. And then obviously the 20% in between was due specifically to the capsaicin. And so their number needed to treat was once again about 6. Now, the interesting thing there is that, if you're going to use the capsaicin, there's a 64% chance you'll get a 30% decrease in your pain. So it's, relatively safe. It's cheap. Reasonable odds of getting moderate improvements in pain. Duloxetine, which we spoke about before within the context of neuropathic pain, which its number to need to treat in that is about 6. Number needed to treat with duloxetine in back pain is 10. So we changed the disease process and all of a sudden you need to actually treat more people to be able to get the equivalent of 30% decrease in pain. So it's the interesting thing with number needed to treat, it's context dependent with regards to whatever you're treating as well. So it's not straightforward, but it gives you a bit of an idea. Importantly, opioids, number need to treat is 16. So I've got to treat 16 people with opioids to get them to get a 30% decrease in pain that's greater than the placebo effect. And so in that, 39% of patients got a 30% decrease in pain. So
yeah, it's interesting that opioids are some of the worst number needed to treat when the perception is that they're very effective, like from
yeah,
a pain patient perspective,
yeah, they're
but they're
not.
not, irregardless of the downstream effects. Yeah, so it's just
Yeah.
very interesting how perception does not always match up with the reality of the effectiveness of these treatments.
What becomes super important out of this is what's the take home. So if you sort of go through all those numbers and you look at them individually, but you sort of just group them broadly, if you're going to look at least what we've spoken about, so exercise, oral anti-inflammatories, capsaicin, duloxetine, acupuncture, that group, there's about a 50% chance you're going to get a 30% decrease in pain. Okay. And so what you can think about there as well, that there's a very good chance that, maybe nobody in the group actually gets 30% decrease in pain because it's an average. They've averaged the response across multiple randomized control trials. It becomes, all right, the average is a 30% improvement. And this is where medicine becomes that, and understanding evidence starts to become more difficult again. This is called the ecological fallacy. And so it's a logical thinking area. And I'll take you through it and how it applies to how we currently do evidence-based medicine, at least evidence-based medicine in how we just focus on the scientific component to it. So let's say that you're in a school group. Okay. So you're in a school class, and what you do is take everybody's height and you then average it. And you get an average height of 5'4". Then you're saying, well, the average height is 5'4". If you've got a kid that's joining the class next week, then if you go, well, where's the class say he's going to be 5'4", it's not likely he's going to be 5'4", because what you've done there is you've taken the average,
The group
data from the group, and you've then applied it to an individual. And if you're thinking about it, like, that fundamentally doesn't make a bunch of sense. And you kind of know it doesn't feel right. But what we do in medicine is we do essentially the same. So let's say that you're a school class of people with back pain. And what we do is we do a study with you and we give you a drug. And out of that drug, what happens is that you get some people that get 100% pain relief, some people that get 50% pain relief, some people that get absolutely no pain relief. And so, because everybody gets different responses. And then if you take, the however many in the class that get different responses, and you then come up with the average in this setting, we're going to say is 30%. But it's quite possible that nobody actually got 30% decrease in pain.
Right.
What they actually got is a couple got 100, a couple got 50, a whole bunch got 0, a couple got 70. By the time you average, you do the maths, the average is a 30% improvement, which is an interesting thought process in itself. So when we're talking to patients and we say, wow, the average improvement in pain from this study was X, Y, and Z. Well,
not
it's
even
an average.
Even it's like an average of an average, like applied to an individual.
Yeah. And so what the next step is let's say that next week you're having somebody join the class that's also got back pain. And what you then say is you say, okay, we're going to take this drug and we're going to give it to this person and they're going to get a 30% decrease in pain. And that's effectively what we do in medicine, which is completely illogical, because the way that individual is going to respond, they may get 100% decrease in pain. They may also get 50, they may get none. And so us taking this process, but what we do is taking the group data and applying it to the individual is known as the ecological fallacy. And it's a logical thinking area. What's interesting with that is that we then take a bunch of randomized control trials and we then do a meta-analysis. And somehow we're actually further away at that point. So just because we've got a bigger average from a larger number of people still doesn't make it logical to apply it to that individual.
Right. It's not more accurate.
And it doesn't make it less illogical. It's still illogical.
Yeah. And I mean, part of the challenge, or the reason why this even happens, is, again, just because of appropriate limitations and, aspects of efficiency that are a part of medicine and how,
Yeah.
we investigate these things.
Yeah, that raised the question of why do we do it this way? And I think the answer
Right.
why we do it this way is because this is the best option we've got at the moment. Okay, so we've built a system around, okay, this is the best option we've got, and this is what we're going to go with. Now, as we move forward, precision medicine, AI, it'll get us to being able to tease out of those studies, well, who is the person that responds 100%,
Right.
who responds 0, who gets worse. Like, we didn't even talk
Right.
about the people that got worse in the
Right.
class, so that we will be able to identify, okay, you're going to get worse, we're not using that medication on
Right.
you,
Try that
you're a
instead.
winner, we're
Yeah.
going to give you that. But we are not there yet. I think it's still going to be some time. Hopefully it's not forever, but it's still going to be some time before we actually get to a point in which, precision medicine and AI are going to allow us to more accurately predict what a response to a patient will be.
Yeah. I mean, essentially individualize the treatment
The
further.
other thing that overcomes the issue we have with randomized control trials and applying that group data to the individuals is then experience. And so the experienced clinician that has seen thousands of patients and read thousands of papers, and let's be honest, made thousands of mistakes and got thousands of things right, what happens over time is you start to be able to pick who will respond and who won't respond. You start to be able to pick particular characteristics in patients that says, okay, I'm going to go with this medication, or I'm going to go with this treatment, or I'm going to go with that treatment, that allows you to better predict why, or helps you to increase the likelihood you're going to have a positive outcome with patients.
Right. You can think outside the group data because you're using your own critical thinking skills from years of accumulated experience and spidey sense that we'll get into.
Yeah. The interesting thing is, there's times you don't know why. You don't know. It's hard to actually verbalize the exact reasons why something is going to take place. You can do it diagnostically. I can watch people get up out of a chair and I'll go, okay, this is a disc. This is a hip. And then I spend, the next period of time trying to prove myself wrong. Okay, that's my first impression, but am I right? Am I wrong? The important bit is to recognize that if you don't respond to a medication, it's okay. If you don't get as much pain relief as you want, it's okay. That puts you in the normal group.
Right.
So it also means don't stay on it forever. The amount of patients that go on to pregabalin and stay on it and are never taken off it, even though they get, less than 30% pain relief and has got a bunch of side effects, is enormous.
A very common one that people are just on.
Yeah. And then people are on it and it becomes really hard to get off. And I think that if you're not getting what you expect, it's okay. You're normal. Move on.
Yeah.
Stop it. Go on to the next thing.
This is also why it's really important to have open, good communication with your physician and have this be a collaborative approach where you can try something, give it its best shot, but then if you don't want to be on it or you don't feel like you can tolerate it anymore, reevaluate it. Similarly, if you have been on something a long time and your symptoms have improved, could you reevaluate the dose you're on? Right? So sometimes it's not even a side effect thing. It's do I need to just by default be on this? And when you look at the number needed to treat concept, what it really highlights for me is that similarly as when you look at the inputs of pain from a treatment perspective too, it's also a bit of a puzzle. It's not one piece, right? Or any one magic bullet, so to speak, that's going to check done. It's what checks off 20, 30%, what impacts 10%, what impacts 20%. And together, right, stimulators, 40%, medications, 20%, right? That's kind of how you can accumulate these different interventions where alone it's not a big enough dent, and that's normal.
Yeah. And, coming back to the evidence-based medicine piece, the definition of evidence-based medicine has been kind of hijacked to being this focus on randomized controlled trials and meta-analysis outcomes. But what the original definition was, it's the best available science with the experience of the clinician and the desires of the patient. And so it's putting those three things together. One of the main skills that I think has been important for me to develop over time is if a patient says, you know what, Dan, I don't want an injection. Okay, great. here's your other options. Dan, I don't want to take medications. Okay, no problems. We can
Right.
look at these interventional options. I don't want injections. I don't want medications. Okay, great. Here are your natural options that you can look at. Here's your rehab options.
Right.
I do get to a point where people say, I don't want medications. I don't want injections. I've already done all the rehab. I don't want surgery. And I've already done the psych. And I'm kind of like, well, I'm now starting to struggle. We're going to throw diet in. I start to struggle at that point. So,
No, Dan, that's when you go, are you sensitized? You might be sensitized. Come over, work on this stuff.
yeah.
I got so much stuff for you.
I think the final point we can take out of this is that there are no magic bullets. So if someone's offering you a magic bullet, it's probably not a magic bullet.
It's a red flag.
A red flag, yeah.
Charlatans.
It's about recognizing that lots of different things will give you a component of pain relief. And really what we want to try and do is we want to shrink down the amount of things that we're doing to better match your symptoms. And so if you can break up your nociceplastic pain into its different features, if you've got inflammatory features to it, use an anti-inflammatory. If you've got myofascial features, get a massage, get your trigger point release. If you've got central sensitization and you've got sleep disturbance or you've got brain fog, treat those. Yeah. But it's not about doing a million different things, and no one thing is going to fix everything.
Yeah, and having appropriate expectations along that process makes it a lot less frustrating as a patient when you realize there's nothing wrong with me. This is normal. Keep going. Try the next thing. And the narrower and more specific and more ideal those options are for you, obviously, the better. So I think that brings us to the end of this episode.
I think it does.
All right. We appreciate having you. See you next time.
Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.